Go to the next one, Dr. Puja Hingorani, to talk on bank tricky tract, the optic nerve.
Yeah. So Tilly's connecting. I just wanted to tell you why I named it this. It's a tricky tract because when we always teach our students, we tell them, oh, it's not a nerve, it's a tract. Because of we usually associate nerve with something that is in the peripheral nervous system, from the sensory receptor to the spinal cord is the nerve. Then from the spinal cord to the lower brain is the tract. That's a second order neuron. And from the lower brain to the higher brain is a third order neuron. And that's the reason, as we all know, that is it seen? It's not. That's the reason, as we all know, the first order neuron is the bipolar cell. Yeah. So this will be a case-based course, a 7-minute course. And so as we know, this first order neuron is the bipolar cell, which is, and the first synapse is the outer plexiform layer. The second synapse is the between the bipolar cell first order neuron and the second order neuron, which is the ganglion cell, which is in the inner plexiform layer. And the third synapse is in the lateral geniculate body, wherein the third order neuron starts. So actually, if we go to see what we are dealing with and what we call the tract, or what we call the optic nerve, is actually a tract, and it extends right from the retina, the pre-papillary part, the papillary part, and the post-papillary part. It's all the same axon. It's not synapsed, right from the retina, the nerve, the optic head, and the up till the LGP. So I'm going to discuss cases on the retina, on the optic nerve, and on the and behind the optic nerve. So these are all diagnostic dilemmas. So there's a 12-year-old male child. Madam has already covered a few, but they're all not typical cases, and that's the why they're dilemmas and they're tricky. So 12-year-old male child brought to the emergency, fever, headache, weakness and inability to walk with urinary retention, very recent, and loss of vision. So I would just like to stress, and if any take home messages, anything related to the optic nerve and beyond, it should be headache or loss of vision, or at least either. Usually both, but sometimes either. So he came to the emergency because these cases usually come to the emergency, but it's a male child. So otherwise, there was nothing great, just no other history, little bit of pallor, systemic was normal. CNS, yeah, lower limb had a little low power, and there were no ankle and knee jerks. So again, we will think of something involving the optic nerve and something that's going on lower down, so something like transverse myelitis. So this is something where we expected, okay, so the vision was PL plus minus, the child was unable to give it, RAPD was there, a small esotropia, not so significant. This is what we saw. So there is a significant edema in the left eye, and that is confirmed by this huge peak here. And if you can see here, the right eye looks normal, but the VEP shows that the latency is raised. So here we have something that's involving possibly both eyes and the spinal cord. We had to go ahead with an MRI. So here it is, the T2 weighted images. There is signal intensities are raised, and in the post contrast, there is a take up, and so this confirms the optic neuritis. There is a longitudinally extensive involvement of the spinal cord, and longitudinally extensive just means that more than 3 vertebrae are involved, across more than 3 vertebrae, and there is an enhancement and enlargement. And here across the T2 vertebra, we see there is a uptake, and this just means that here the channel, the aquaporin can. This is the nerve. There's the myelin sheath. So the myelin sheath itself has the MOG, or the myelin oligodendrocyte glycoprotein, which can have an antibody, or the aquaporin, where the blood-brain barrier is situated. So either of these can have antibodies. So if there's an aquaporin antibody, this is how the damage occurs. And if there's an MOG antibody, this is how that damage occurs, and the myelin is lost. So that's why these neuromyelitis optica was our clinical diagnosis, because these are the criteria. So we went ahead for both the antibodies, both were negative. Both were negative. So we went ahead for the criteria which says if the aquaporin is negative, does the child, does the patient, fulfill these criteria? He fulfilled all of them, and even MOG was negative. So we started on IVMP with the pediatrics department, obviously. There was some benefit. From no PL or plus minus PL came to 2/60, and there was some neurological improvement. So as I showed you in these diagrams, there's a lot of IgG all around. So what they did was they went ahead and gave IV immunoglobulin and prednisolone, and the child came to 6/6. Now and they discharged the child walking. So the child had weakness. He went walking. He went 6/6. He went on a mycophenolate. This was the final picture. There's some pallor, yes, and yeah, there are some RNFL zones which are thinned out. So what was critical here was, usually it's the female sex that's involved. Look at the age that should be involved, 40 to 60. It's associated with other diseases. The IgG helped us to, give the antibody IV. That helped. And here it says poor recovery, but luckily for this child, male, 12-year-old, recovered fully. So not a classical case. There's another case, 47-year-old male. Diminution of vision only in right eye, 2 days, just a 2-day history. What happened? What happened? Look at this. What is this? What would you think of? So this is how the picture was. Huge disc, optic disc. Malignant hypertension. So we referred to medicine. The patient was treated, came back with 6/6, resolved somewhat. You can see the succinate maculopathy coming up, a few flame-shaped hemorrhages here and there. This was a second visit. BP better and well controlled. Yeah, but he's going into some atrophy here. And this is almost like a secondary optic atrophy settling in. And yeah, so he didn't come to 6/6, he came to 6/12. And it's not a very good post-neuritic picture. There's another patient, 33-year-old, gradual diminution of vision since 1 month, but nausea and vomiting. 6/12, both eyes, frank papilledema. Now, this is quite classical. I thought, like, can't be all atypical cases. Yeah, so grade 4. And CP angle tumor diagnosed as acoustic neuroma. Another patient, 27-year-old, headache since 4 to 6 years, 6/6. So here there's no loss of vision, but there's a headache. As I told you, it could be headache or loss of vision or both or either, mostly. So, but there was some reduced hearing. So look at this. There's no papilledema either, right? But I would show you these. There are some cotton wool spots. There is some hemorrhage here near the disc. And look at this. In the right eye, again some hemorrhage. There is cotton wool spots, AV crossing changes, hemorrhages. So it's a grade 3 hypertensive retinopathy. So why would a 26-year-old, 27-year-old have a hypertensive retinopathy and a long-standing one at that? So disc appears okay. So what? So we did a medicine referral. It was hypertensive, concentric LV atrophy, hypertrophy. But then there's something in this disc which doesn't feel right. And there's that headache. So we did an MRI. Just look at these ventricles. So it is a communicated hydrocephalus. This is a T2 weighted. You can see patient was sent to neurology, acetazolamide was given. So there was another one, second month, first trimester of surgery. Yeah, first trimester of pregnancy. Left eye, 6/18. Nothing really, no? Can you see anything? No. But there is a bulge here. Just above the disc, there is a small bulge. Unfortunately, I can't show you a 3D image. And there's that bulge, which is seen. This was done outside, not at our center, the tests. Vision further dropped to 6/60. It's a pregnant lady. We advise an HFA and an MRI. And here's a meningioma. There's the 26-year-old male this time. Left blurring of vision 3 to 4 weeks associated with headache. 3 to 4 weeks associated with headache. This is the vision. Now, here, if not anywhere, the importance of history. Everything is normal, ESR is normal, everything is normal, and ma'am has already shown such cases. And look at this, but it's unilateral. And ma'am had classically said that these will appear bilateral because the history is, and this is elevated. You can see only on one side. Ayurvedic treatment. He had to stop Ayurvedic treatment. We gave him, it didn't have a centrocecal classical scotoma, but yeah, blind spot was enlarged. So we gave him 4 doses of IV methylprednisolone, resolved to 6/6. This is a post-treatment picture. It's still on the resolving stage. This is something, last case, had a history 1.5 years ago of vitrectomy, membrane peeling, endolaser, and cryotherapy. 6/60 in the left eye. This was the past picture for which vitrectomy was done. This was not done at our place. This is how she presented to us. Disc edema and diagnosis of hemangioblastoma. This is a peripheral cryotherapy that was done and presenting as disc edema. So here again, this is the classical picture. And one, as I go, one for you. What do you think is this? Madam has already given huge clues. Neuroretinitis, secondary to something. Yeah, so here again, if I can stress upon the fact that the history is very important, and this is the red-free images, cotton wool spots, the OCT, and finally it was turned out to be post-typhoid. So as we saw 2 cases belonging to this part of the axon, 2 to the papilla, and 4 to the remaining part. And